we're looking forward to your talk, AK, on intraoperative challenges in localizing conduction tissue in congenital heart disease.
Thank you, Shelley, and thank you everybody for attending this inaugural meeting. And like Shelley said, this is a meeting that's sponsored by the NIH and NHLBI under the R13 mechanism, and we're certainly grateful for the institutes for supporting our work. And our team has been funded through the years by different grants from the NIH, which includes R21, R56, and UO award from the FDA, and currently an R01. We don't have any other financial disclosures. The senior department wanted me to illustrate some learning objectives. Basically, what we want to talk about today is understand the anatomy of the conduction system. We gleaned a lot from Dr. Sanders. It's hard to follow that, but I thought I'd basically touch on it. Some pathologic studies that illustrate this, and variations of this conduction system in complex congenital heart defects. And the question that Luis asked, what is this injury to the conduction system and the complications associated with it? And brainstorm about ways in which we can overcome this problem. So most of our understanding is based on pathologic examination from the 60s, 70s, 80s, Jesse Edwards, Richard and Stella Van Praag, Dr. Anderson, and Steve Sanders. And as Dr. Sanders showed, most of the depiction of the conduction system consists of the sinoatrial node in the superior vena cava atrial junction and the AV node in the triangle of Koch near the membranous septum. Obviously, complex lesions have significant variability in the location of the AV node. And most importantly, the length of the His bundle and where they bifurcate into the right and left bundles. And as we know, intraoperatively, there's distortive effects of these complex cardiac lesions on the various anatomic fiducials that we rely on. So why is this a problem? This is a graph from our grant, and I have the citations for this. Even simple defects such as VSDs, tetralogy, and Fallot, the incidence of heart block requiring pacemaker placement can be as high as 1 to 3%. If you go to complex defects such as canals or certain types of transpositions, heterotaxy syndromes, and corrective transposition, the need for pacemakers for heart block after surgery can be as high as anywhere from 7 to 50%. But this is looking at conduction abnormality as a binary parameter. We think of, it's either the conduction system is injured, you need a pacemaker, or you don't need a pacemaker. But I draw your attention to this, which is short of needing a pacemaker, even patients with simple defects such as VSDs, canals, and tetralogies, up to 50 to 90% of these patients have conduction abnormalities, right bundle branch blocks, in certain cases, left bundle branch blocks, superior axis deviation. So this is a significant problem, and also reframes the question as thinking about cardiac conductive health as less of a binary parameter, but more of a continuous variable of conduction health. And this is the classic picture that Dr. Sanders showed us of the conduction of the AV node in the triangle of Koch, the penetrating bundle in the membranous septum. A simplified view of this, but what we found, even in our laboratory examinations, paper published in the Heart Rhythm Society, it's this human tissue from normal hearts, patient with ASD, VSD, and a patient with L-looped ventricles. And as you can see, even from our histological assessment, using different Mason strike chrome staining, we see that there's significant variability in the location of the AV node, and more importantly, significant variability in the length of the His bundle and where it bifurcates. And in this particular case of corrective transposition, this patient had dual nodes. So there's two nodes, one outside the triangle of Koch as well. So this is the problem. It's enormous variability, a high instance of conduction abnormalities short of heart block. So this is the problem. So Luis had asked, what is this? How is this related to surgery and what we do? This is a paper from a long time ago from Rochester, Minnesota. It's Dr. Jesse Edwards' group. Jack Titus is the lead author on this paper. Basically, what they looked at postmortem hearts of patients who succumbed after repair of a VSD. Dr. Del showed it was as high as 13, 15% that they succumbed after VSD closure. These were patients who had heart block. And basically, looking at their hearts, he saw complete traumatic disruption at the his bundle location. First, one of the earliest evidence that it's mechanical disruption that's one of the causative agents of heart block in these patients. So they went on further. They looked at all of these patients, 7 to 15 were the patients that they examined. And the mechanisms that resulted in heart block include, direct injury from suture, but interestingly, hemorrhage and infarction. So a lot of trauma from suturing, but also probably disrupting some capillary endothelial interface near the his bundle, making it ischemic or distorting it in some fashion. So again, makes you think about, is suturing the only way of repairing these defects, right? It's a few of them have direct traumatic injury, but a lot of them have hemorrhage and it resultant injury from tissue kind of trauma. So why is conduction block relevant? Obviously, patients that don't have complete heart block still require medical therapy for impaired ventricular function resulting from either a dense right or left bundle branch block. As we see the tetralogy of Fallot that have been repaired in the 80s and 90s, surviving to their 30s and 40s, we see that even these disruptions in conduction have significant effect on their ventricular function and functional outcomes. Obviously, it's more evident in patients that require device therapy, pacemaker placement for heart block, the cost of device therapy. And we presented this at our Heart Rhythm Society 4 years ago, similar to data that Dr. Del showed. The societal direct and indirect cost of pacemaker therapy is close to $250,000. The problem is once you have issues related to device malfunction or infections, these costs skyrocket. So there's significant morbidity associated with these devices. So I wanted to look at variability in locations of the AV node, his bundle locations in 4 complex lesions, double outlet right ventricles, heterotaxy syndromes, corrected transposition, and complex AV canals. Obviously, a lot of histologic stuff, but overlaps with what Dr. Sanders had showed us. Looking at DORB, a lot of complex forms now routinely are referred for biventricular repairs. And there's differences in the conduction pattern with respect to location of the AV node and also the length of the his bundle prior to bifurcation. There's also significant variability with respect to bundle branch location in relation to the crest of the ventricular septum. This is a paper from the Powerhouse group in Chicago, looking at conduction system in double outlet ventricle, subpulmonary VSD group. And basically, this figure illustrates to the left of your screen is the left side of the heart, to the right of the screen is the right side of the heart. The mitral valve indicated by MV, tricuspid valve indicated by TB, you can see it very clearly. And D is the ventricular septal defect. And the crest of the ventricular septum, you can see the his bundle, which is marked by the 2 arrows. And next, you see the location of the bundle branches. In this particular specimen, you can see that the bundle branches are quite far away from the crest of the ventricular septum, the left bundle being very superficial, and the right bundle being a little insulated on the right ventricular aspect of the crest of the septum. In another specimen, you see the same bundle branches, where the right bundle is a little more closer to the crest of the ventricular septum and a little more superficial, similar to the depth of the left bundle branch block. Given this pathologic examination, it's clear that there's significant variability in location of the bundle branches with regards to the crest of the ventricular septum and also the depth of the bundle branches. How about in heterotaxy syndrome? Obviously, Dr. Sanders had shown a nice summary of these, but as we see intraoperatively, there's significant variability in systemic and pulmonary venous drainage. In certain heterotaxic syndromes with VORB, we potentially need to enlarge the VSD in these patients. And there's unpredictability in the number of AV nodes, the location of the AV node, and the His bundle. And obviously, there's significant distortion of these fiducials we rely on based on underlying lesions. Say a left SVC to a dilated coronary sinus. Now suddenly it's disordered the triangle of Koch as we think about it and where the AV node would be. And looking at a picture from this paper in Clinical Electrophysiology, it's a depiction. I mean, this is the paper I'm going to use to depict the lesion in these complex defects. You can see a view with the RV and the right atrium carved out. This particular variation of heterotaxy shows ipsilateral drainage of the pulmonary veins and a left SVC with pulmonary atresia and an AV canal. As you can see, they can have an anterior and a posterior AV node and with variable arborization of the bundle branches. And this was also shown by this Japanese group where these patients with heterotaxy, about 20% of them can have this posterior and anterior AV nodes. And on the histologic examination, you can see the crest of the ventricular septum caudally and the membranous septal aspect cephalically. And you can see both the nodal components surrounding this ventricular septal defect. And this is where the two anterior and posterior nodes come together to arborize into the right and left bundles. And this is an intraoperative depiction with the green star showing the posterior and anterior AV nodes and the blue triangle marking the crest of the ventricular septum. Again, significant variability in the number of nodes and the location in this particular case of heterotaxy. How about corrective transposition? This is a lesion that more and more patients are referred to for anatomic repair, which is to use the LV as their systemic ventricle. Obviously, significant variability in the His bundle branching and arborization. There's also potential for dual AV node, with about 5 to 10% of these patients having dual nodes. And as the electrophysiologists would like to remind us, they have significant pre-existing fragility in their AV conduction. And quite a few of them have pacemakers implanted even prior to their anatomic repairs. Again, the same cartoon from this paper showing what the conduction would look like with a single node and a dual node. With a single node, you see the dominant node in the region of the membranous septum. But here, it traverses close to the pulmonary valve annulus, which is outflow for the left ventricle, and courses superiorly and leftward of the ventricular septal defect, which is the opposite of what we see for a traditional ventricular septal defect. If they have a second dual node, the dual node follows the pathway of the traditional His bundle that we like to think about. And these broad fronds are the left bundle branch, which is supplying the systemic anterior left ventricle. And the posterior frond is the right bundle supplying the posterior right ventricle. This is a review from the Journal American Heart Association, again illustrating this point, which is, let's just focus on situs solitus. It's the penetrating bundle, which penetrates cephalad close to the pulmonary valve annulus and traverses close to the edge of the pulmonary trunk. So in cases of patients with pulmonary atresia, it's imperative that we not divide this pulmonary trunk for fear of causing heart block, instead rely on a conduit type arrangement. The same thing illustrated in a post-mortem analysis of heart, the anterior connecting node, which is the most common site of the AV node, and how the left bundle branches arborize along the ventricular septum and along the superior and leftward aspect of the VSD. And the smaller red dot close to the coronary sinus would be the posterior node in the traditional location we'd expect for a AV node. How about in cases of AV canal? Again, from Dr. Sanders' lecture, we understand that it's most of the time it's in a fixed position, but there's also significant variability in the membranous septum, how typically displaced is the AV node in these canals, and depending on other anatomical distortions, such as the primum, secundum defects, the coronary sinus, the VSD, and also inconsistency in the length of the His bundle prior to bifurcation. Again, the same cartoon shown from his paper with the right atrium and right ventricle cut out. It shows the AV node in the triangle of Koch, and then the His bundle penetrating the membranous septum. The dark red line shows the right bundle, and the hash line is on the other side of the ventricular septum, which is the left bundle. How does this look histologically? This is from the group at Leiden, showing us how embryologically these conduction patterns come about. It's the AV node, and as the primordial sac develops, how these bundle branches arborize across the ventricular septum and supply the respective ventricles. The same group did histologic analysis, again, showing that the penetrating bundle, as shown by PB, and the right and left bundle branches. This figure is a little opposite of the figure we had seen initially from the group in Chicago, with the left side of the screen showing the right heart and the right side of the screen showing the left heart, and the right bundle and the left bundle. Again, as we've noticed in the operating room, we try to put our stitches as far away from the crest of the ventricular septum. But as you can see, depending on where the right bundle is, it's very easy to disrupt these right bundles in these patients with the AV canal. Finally, how can we avoid injury to the conduction system? Obviously, understanding the variability in this conduction tissue in different lesions is paramount. Preoperative modeling to help provide adequate fiducials for us, and new intraoperative technologies to help guide this visualization, be it the His bundle signal, histologic examination, and what type of intraoperative fiducials in an open heart, beating or non-beating, that can help guide preservation of this conduction tissue. And this is finally controversial. I mean, is there a threshold to revise the surgical repair if there's evidence of heart block when you come off bypass? But then you look at Dr. Walsh's paper, which says there's several days for conduction to recover. Say 8 days, it doesn't recover. Do you go back and revise your patch? It's a lot to ask, right? And as we saw from the paper from Dr. Edwards' group at Rochester, it's a lot of trauma, right? I mean, it's not direct suture injury to this bundle of all these patients. There's hemorrhage, hematoma, ischemia from the suturing. So is suturing the only way to repair these defects? I mean, can we glue these? Remember that paper in Nature from Lang and Del Nido talking about a glue? Is there some other alternate ways of anchoring these patches without traumatizing the myocardium? So to summarize, I think there's significant variability in the known location of conduction system in complex cardiac defects. The anatomic fiducials that we rely on are frequently distorted in complex defects. Technological development assistance to help determine location of these conductive pathways provides us the best chance of identifying and preserving these pathways. And finally, I implore everybody to think of conductive health as a continuous parameter. I mean, I talked to Lizzie and other electrophysiologists. I mean, our traditional thinking that it's heart block or no heart block, I think we need to get away from those gross parameters, but as this continuous thing, as a global rank score parameter, where you think of different grades of conductive health and how these impact the patient's overall health in the long term. I thank everybody for attending this conference. I'd be happy to take any questions.